Assessing support provision for disabled medical students, a quality improvement project at the University of Leeds. This presentation consists of the following: an introduction of who I am, my role and what the University of Leeds set out to do, the definition of disability, the background of disabled medical students and doctors, the challenges for disabled medical students, an overview of the 2019 General Medical Council Welcomed and Valued Guidance, the support assessment at the University of Leeds, and lessons learnt through this assessment that could be applicable to other areas of practice and other vocational courses. To introduce myself, I am Sarah Martell, a rehabilitation doctor in West Yorkshire. I have undertaken a one-year post as a leadership fellow with the University of Leeds. The university recruited 2 leadership fellows to assess support provision for disabled medical students. This was following the 2019 release of the General Medical Council Welcomed and Valued Guidance. This is a document advising on best practice for undergraduate and postgraduate institutions on supporting disabled medical students. Firstly, to quickly recap the legal definition of disability using the 2010 Equality Act, as I know this will be very familiar to many delegates of this conference. Disability is an impairment that has a substantial, long-term adverse effect on a person's ability to carry out normal day-to-day activities. Substantial means it is more than minor or trivial. Long-term means it has or is likely to last more than 12 months. Normal day-to-day activities include things people do on a regular basis, including work. An impairment is an injury, illness, or congenital condition that causes or is likely to cause a loss or difference of physiological and psychological function. Using the social model of disability, a disabled person is a person with an impairment who experiences disability due to the social and environmental barriers existing within society, rather than because of their impairment. The definition includes medical and mental health conditions, therefore the definition has expanded over time. Background. As most of you in the audience are aware, there is 13.9 million disabled people in the UK, which is approximately 1 in 5 people. This includes 3.7 million disabled people in work. The number of disabled medical students is increasing, as the definition of disability has widened, with 2.6% of medical students in the UK classified as having a disability. The percentage of disabled doctors in the medical workforce is estimated to be slightly lower, between 0.26 and 1.12%, and it's not known if this is due to students and doctors leaving the profession, an increase in the number of admissions of disabled students to medical school, or if disclosure of disability is lower amongst doctors in comparison with the students. So why is it important to have disabled medical students and doctors? To reflect the population using the health service, which as we know is a very diverse population. It helps utilise the strengths that disabled employees can bring to the workforce, such as additional skills, increasing the number of high quality applicants, and also in medicine to have a doctor who has a first-hand understanding of disability. To improve services for all users, as there are studies highlighting that having a disability actually improves the doctor-patient relationship. This might be because of improved empathy and insight amongst disabled doctors, which is a unique aspect which cannot be replicated amongst the general medical student population. Disabled doctors can also improve the perception of disability amongst patients, colleagues and the wider service, and this contributes towards an increased acceptance of disability. It finally is crucial for the medical schools and the NHS to use adaptations to retain experience and knowledge that disabled doctors bring. It is important not to lose these valuable people if their disability is a barrier to a successful work life. Unique aspects to medicine. At this point in the presentation, it may be helpful to understand the background of medical training and the regulatory body. Medical training continues beyond 5 years at medical school, as postgraduate doctors continue their training for at least a further 5 years as a GP or for 9 years as a hospital specialist. Guidance therefore applies to postgraduate educators as well as medical schools, but for the purpose of this presentation, I will focus on undergraduate medical school training. A unique aspect of a professional degree includes a student not only has to satisfy university standards to gain their degree, but also meet the requirements of the regulatory body, for example in medicine, the General Medical Council, or GMC. Medical schools are required to only accept candidates onto their course who can meet the compulsory GMC criteria to become a doctor, and these are set out in the documents Fitness to Practice and Outcomes for Graduates. General Medical Council requirements. Outcomes for Graduates is a document that determines standards for assessments and qualification required to graduate as a doctor. Within this context, it advises on standards for graduating students with the appropriate support. Fitness to Practice is a document used to ensure competence so that doctors may practice safely. A fitness to practice concern in this context would include if a doctor's health is compromising patient safety. It is important to emphasise that being disabled is not automatically a fitness to practice concern, and each case must assess the impact of disability on the person's ability to practice medicine safely. It is important to highlight that if students are not able to meet outcomes for graduates with the appropriate support, students should be offered support to overcome the concerns and access to alternative career options, and this includes pathways to gain alternative qualification. Changes from the GMC. In 2013, positive improvements were made for disabled medical students, including the recognition from the GMC regarding the performance of CPR. CPR stands for cardiopulmonary resuscitation, which is carried out on patients in cardiac arrest. When this happens in a hospital, a crash team is called, which enables a team of people, of doctors, nurses and other healthcare professionals to be immediately summoned to perform CPR. This act requires physical skills from the team, but also the most senior member of the team, who is generally a doctor, to lead the team verbally. Prior to 2013, the GMC required medical students to carry out the physical act of chest compressions in CPR in order to graduate and be part of a crash team. This was a barrier to many people with physical impairments to becoming a doctor. However, recognition has now been given from the GMC to clarify disabled trainees and medical students are not required to carry out CPR if they are unable to do so. The requirement is now that they can lead the crash team verbally, and this has been a very positive and meaningful change. Further changes from the GMC. In medicine, supporting disabled students is the responsibility of the higher education institution. However, the regulatory body also plays a key role. This is demonstrated through the publication of the GMC's Welcomed and Valued Guidance in 2019, which used expert opinion and personal experience to advise universities to support disabled students within the medical training. At the University of Leeds, our team developed a toolkit from this extensive 110-page guidance and applied it to their institution. 3 key areas were identified within the guidance of admissions, assessment, and clinical placement delivery. Another unique aspect of vocational degrees is the clinical placements. A core part of the medical course includes placements. Many undergraduate courses send students outside of their institution for over 50% of the contact time. This requires close partnerships between the medical school and the key partners, including NHS trusts and GP practices, to create successful learning environments. This can be difficult to implement equally across all the different areas. For example, in Leeds they have partnerships with 9 different NHS trusts and 120 GP practices in the community. For disabled students, this partnership will encompass the provision of adequate reasonable adjustments to accommodate their needs, whilst ensuring access to appropriate student support whilst on placement. Barriers and challenges. Other barriers also still do remain for disabled students, and the situation at present is not without its challenges. Some examples include less than full-time training is not available for undergraduate students at any UK medical school. thus not allowing for those whose disability may require them to have rest days due to fatigue or for maintenance of medical appointments or treatments. Postgraduate training, however, does have allowances for this. Challenges to perception of the role of the doctor also exist by patients, colleagues and the general public. There are many anecdotal accounts of disabled students and doctors not being treated fairly in the workplace or being negatively discriminated against by their patients or work colleagues. New challenges have now emerged for educators to provide teaching suitable for disabled students in the context of virtual learning in the pandemic. Considering that many of these students will have had to shield or had significantly reduced clinical time, as well as the areas of clinical practice that are still restricted for students, this leads us to enormous challenges for the typical clinical years, which are the 3rd, 4th and 5th years of medical school. This brings me to the point that more students will declare as having a disability that may not have done so previously if they did not feel their condition warranted declaration. However, now with COVID-19 this is unavoidable. For example, a student taking immunosuppressive medication with the need for shielding and reduced clinical contact. Disabled medical students in Leeds. This graph shows a breakdown of the classification of disability within Leeds Medical School years 2019 to 2020, which by comparison with the rest of the UK has a relatively high intake of disabled medical students, 17%, compared with the UK average of 2.6%. The figures for the past 5 years support this, indicating Leeds accepts a comparatively high proportion of disabled students to the medical school. Specific learning disability is by far the most common type of disability amongst these students, but there is a variety of types of disability and therefore a variety of needs to be supported within this cohort. It is important to note that this information is only of declared disabilities and therefore there is likely to be many more in the student population. Declaration of disability has no impact to the individual with respect to their studies. However, students may not disclose conditions that they consider irrelevant to their studies or for fear of disclosure affecting their studies in some way. The GMC welcomed and valued guidance. For this presentation, I'll be focusing on this area of guidance as it encompasses all the legal requirements, mandatory GMC requirements, and also suggested best practice to support disabled medical students throughout their training. This document is useful for medical schools to understand best practice. It is also designed for postgraduate educators, but I'll be focusing on medical school rather than postgraduate training. The guidance also mentions its usefulness amongst medical students, both prospective and current, and doctors with long-term health conditions and disabilities. A document of its kind has not been previously released by the GMC, therefore it's new in its concept and is readily viewed on the web, including accessible versions. A link to this document will be made available at the end of this presentation if you should wish to view it in full. To give an overview of the standards that are discussed within Welcomed and Valued, it is helpful to think of the guidance split into 3 key areas. Number 1, the legal requirements which must be met. These are set out by the Equality Act. Number 2, the mandatory requirements which must be met. These are set out in the documents described earlier, Fitness to Practice and Outcomes for Graduates, and another document promoting excellence. Whilst we will not be focusing on these documents in detail for this presentation, it is helpful to know what they cover. And number 3, the guidance suggested within Welcomed and Valued regarding support of disabled medical students. While this guidance is not mandatory or required by law, it is strongly recommended that the medical schools follow this advice and try to implement it within their systems. The law. Firstly, a very quick summary of the equality legislation derived from the Equality Act, as I know this will be very familiar to many of you. It advises to avoid direct discrimination, avoid indirect discrimination, avoid victimisation and harassment, ensure learners are not disadvantaged by the way an organisation does something, positive discrimination does not exist, and the schools have a duty to make reasonable adjustments for the students. Organisations may like to keep an audit trail to demonstrate they have considered whether an adjustment is reasonable, including how they assessed and balanced different factors for each case. GMC standards. I have mentioned outcomes for graduates and fitness to practice documents earlier in this presentation. A further mandatory document promoting excellence essentially sets standards for the medical schools and highlights how schools should ensure students have access to resources for health support and well-being, not subject students to behaviour that undermines their professional confidence, performance or self-esteem, and make reasonable adjustments for learners. Reasonable adjustments. As most of you know, these are changes that are made to ensure a disabled student is not disadvantaged whilst completing their studies. Points considered for assessing whether an adjustment is reasonable include how effective is the change to overcome the disadvantage, how practical is the adjustment, what is the cost of the adjustment, and the resources and availability of financial support. Further guidance also suggests to avoid substantial disadvantage by the way things are done, for example a physical barrier or an absence of an aid, to think again if the adjustment is not successful, and to use a case-by-case assessment, considering support and deciding what adjustments would be reasonable for each person's circumstances and the barriers that they are experiencing. When adjustments are not reasonable includes when they are not effective, when they are a risk to learners or others, and when they require a reduced competency of the learner, which means they would not be able to meet the GMC outcome for graduates. Welcomed and valued guidance. Now I have outlined the compulsory areas for medical schools to adhere to, this is the recommended advice for supporting disabled learners. The document in full, 110 pages, is too lengthy to be described in its entirety for this presentation. Therefore, I've included some of the key messages and areas that have been useful for the review of the University of Leeds. Key messages throughout include to empower students, to encourage early disclosure of disability, to promote health and well-being, to champion accessibility and inclusivity, and to complete regular, continuous reviews. The guidance can also be broken down into 3 specific areas of focus, which include induction and admission, assessment, and clinical placement. General guidance. First of all, there are generic points within the document which can be applied to most areas of the medical school and indeed other vocational degrees. It includes anticipating the needs of potential students, even if the school does not currently have students with this disability. This is admittedly a difficult and time-consuming task to anticipate all disabilities. However, schools may find it sufficient to anticipate types of disability and what needs may need to be met. This could expedite the process of presenting reasonable adjustments, but it's important to bear in mind every student will be different and there will not be a one-size-fits-all approach. Therefore, adjustments need to be offered on a case-by-case basis. Health clearance and occupational health disclosure should be used to identify the students. There may be problems with this due to lack of disclosure, with potential for further research in this area regarding student beliefs, as some may not classify their health condition as a disability. Ensure no organisational or physical barriers, and provide support, including the availability of mentoring and coaching and a named contact at the medical school. For this, they recommend a stepwise model. Here is an example of the recommended stepwise model used for a disabled student. Step 1. Form a support group for the student. Step 2. Decide on key contacts. Step 3. Agree confidentiality arrangements. Step 4. Reach a shared decision on how the student would be affected by the demands of the course. Step 5. Deciding whether a student can be supported to meet the competence standards set out in Outcomes for Graduates. If the student can be supported to meet the outcomes, the school must help them in doing so. If the school decides that a student cannot be supported to meet the outcomes, they must encourage the student to consider alternative options, including gaining an alternative degree and other career advice. Step 6. Forming an action plan. The action plan may elaborate on support in each component of the course, as well as care arrangements for the students. Step 7. Implement, monitor and review this plan. Implementing the action plan is a shared responsibility between the medical school and the student. As highlighted previously, it is important to review if the plan is working on a regular basis. Introduction and admission. One of the key areas in Welcomed and Valued is admission to medical school. This will likely include guidance relevant to other degrees, as the admissions process may be similar. Schools are advised to provide induction material, including contact details for disability services and student support services. Schools may also wish to provide links to relevant content, such as GMC podcasts, Able Medics, which is anecdotal material from disabled doctors. Face-to-face induction. This should include case examples. This can either be from anonymous prior students willing to share their history or face-to-face with disabled students or doctors. Encourage early disclosure. This should be done during the admissions process and also during induction to medical school. Refresher sessions should be provided throughout the course for those who have become disabled during the time of the course, but also as a reminder for students of what support is available. Include information about DSA, Disability Support Allowance, and signpost services able to provide further financial support. Assessment. A further key area is assessment, in which your institution will likely already have measures in place similar to those advised. Physical and organisational, e.g. extra time, regular breaks, rest stations, coloured paper or use of computers. Feedback from students about support available and their effect on assessments. Use of passports or support cards for assessments, which are essentially documents detailing of what adjustments are required, which are widely understood by examiners, eliminating the need for students to explain themselves, particularly within clinical exams, either with real patients or actors. Automatically getting support for each assessment without having to reapply. Clinical placements. A further key area is clinical placements, and this guidance is likely to be applicable to vocational degrees where a considerable amount of teaching time is spent off campus. In medicine, this is generally in NHS partners. They advise designated contacts in the hospitals and GPs. Early information given about placements, location and rotas. Preparatory sessions for clinical practice. This could include shadowing prior to placements or virtual tours of the buildings for students to familiarise with themselves with the area, to access the facilities and to reduce anxiety prior to placement. Training for clinical supervisors. Passports or support cards, which would be similar to those mentioned in assessment, and providing a meeting prior to clinical placements with the student support group to ensure their learning needs will be met. Below also show some other suggestions which may be quite broad and require the school to define how these could be achieved within their environment. Create a positive culture. Have a clear established process for disabled students. Ensure effective communication. Create individualised tailored support. Create an inclusive learning environment and invest in staff training and workshops. The review in Leeds. 2 researchers at the University of Leeds worked to create a toolkit from these documents by which the university could assess the undergraduate course. Standards were set by deriving questions from the documents. The questions were written independently, then reviewed collaboratively by both researchers to ensure questions remained representative of the guidance. The questions were then divided into appropriate departments within the medical school, with several questions repeated in all applicable departments. Generic and reasonable adjustments applied to all departments. For the purpose of this presentation, I will not be given details of all results, but give a more general overview of the recommendations, which is likely to be more applicable to the other institutions. What we learned from Welcomed and Valued. Application of the toolkit identified areas of excellence and areas of potential development. It was concluded that as both admissions and assessment are university-wide processes, this may account for being areas of good practice. Other areas that were university-wide, such as student support and disability services, also scored well, but still had room for improvement with specific issues. For example, student support had bottlenecks within the communication system due to one person being the point of access for students, and disability services lacked case-based examples for students and did not provide regular review of reasonable adjustments. However, the area of interest which is very specific to medicine is clinical placements, which did not score as highly. This is due to the university overseeing but not having overall control of the processes occurring outside of the university walls, i.e. in the NHS institutions. One of the main barriers encountered within clinical placements included communication issues between the medical school and partner institutions within the NHS, emphasising the importance of clear responsibilities. And overall, the importance of disability awareness among staff and students was highlighted, as often support was available but not always signposted, and how increased awareness could improve engagement of the students to comply with disability assessment and access the appropriate support. Recommendations. Despite receiving high scores, simple recommendations were still made for induction to use case-based examples of disabled students with example support and reasonable adjustments available. This could be accomplished by arranging previous students to partake in the induction. It could also benefit the students to understand what disability services offer and encourage engagement with the services. Assessment was also recommended to consider introducing an explanation of reasonable adjustments within the examiner training scheme, focusing on what would be expected from the examiner. For the communication issues within student support, a generic email address could be used to allow staff to access emails in the event of absence and share the large workload. And disability services were recommended to consider implementing regular review of disabled students at least annually. They should provide information in an easily accessible format to students about how to seek review if their needs change. Recommendations within placement were not as straightforward, and therefore firstly would require a further project to identify the processes within each NHS trust, in order to address the issues at each placement. The medical school were also advised to consider creating a database of what adjustments are available at each placement, therefore allowing placement of students to where their needs could best be met. Anonymised reasonable adjustments could be centrally located and linked with a diagnosis on a database, including student feedback on the adjustments. This could then be used for future students when considering adjustments and their historical efficacy. Furthermore, it was recommending that a training package was provided for disabled students to allow them to have autonomy over the process, with a broad summary of the support available, the type of reasonable adjustments, and the processes in the university, including the legal requirements. Key messages. In addition to the recommendations, the following key messages from Welcomed and Valued were deemed helpful to create a positive culture when implementing any changes. Students should be in control of their support, reasonable adjustments, and who the information is disclosed to. This could help mitigate some of the issues of poor communication between departments, particularly when students are on placements. However, this may be difficult for students with poor compliance with services. Students should be supported throughout the process of disclosure and their decision making. And disseminating information and successful processes between departments could encourage sharing of effective practice. Ultimately, using this approach led to highlighting key gaps within the system to improve upon, to avoid barriers for disabled students graduating and going on to have successful careers. Lessons learned from supporting disabled students in undergraduate medicine may also be applicable to postgraduate education as well as other vocational degrees. Conclusion. Vocational degrees like medicine have regulatory bodies such as the GMC that set standards on who can be admitted to medical school and graduate as a doctor. Within the GMC, there has been an organisational change over the past 10 years to allow more disabled people become successful at graduating from medical school, through the introduction of the Welcomed and Valued document and changes to the guidance regarding CPR. Whilst the University of Leeds is doing well at following this guidance within the university-wide processes, there is still room for further improvement and calls for a cultural change to ensure NHS partners are in line with this shift. What we can do as education providers includes being proactive, not only at admissions and assessment processes, but also encouraging and sharing good practice with the NHS partners to ensure continued excellence on placements. Thank you for listening. This is a link to the GMC Welcomed and Valued Guidance. I welcome any questions to please be emailed to admin@nadp-uk.org. Please see the next page for references. Thank you.